I'll tell you, one of the bullets on here that appeals to me is the primary care doctor shortage.
I agree.
How can we reinvent the system?
What do we do?
We can't reinvent the system until we reform the academic institutions who train our physicians.
Right.
And the medical model they follow is, I don't think anything's changed, is designed to push people into the specialties because that's where the best and the brightest go. And if you go into primary care, you're probably at the bottom of the class because people don't choose it.
Not just the bottom of the class, but you're at the bottom of the dollar barrel, too.
Yeah.
And I think that's the real bottom line.
But what I'm saying is the model that doctors train under de-emphasizes the value of primary care. Now, primary care is probably the most important piece of the pie right now.
Family practitioners were making $400,000 and cardiologists were making $100,000. If that would change?
Yes, absolutely.
What do you think?
In a heartbeat. In a heartbeat.
Do you think the training would change is what I mean. I think it might.
Well, no, but we've got to, they're being trained in a model that was designed half a century ago.
Exactly.
You know, and unless we get at the root cause of this, you're not going to deal with this issue.
I don't think there are but two ways to deal with it. One is that you got to pay them more.
Yeah, it's money.
That's right.
Or you got to replace them with paraprofessionals or allied health professionals.
Mm-hmm.
Well, let's face it, there's a lot of models, a lot of physicians in primary care that are using the extenders, the PAs,
Well, they got no
nurse
choice,
assistants.
yeah.
Well, and frankly,
You don't
you
need
get
it.
pretty good care from those people, by and large. You know, if they're smart enough to know when to make sure the doc gets involved. I mean, that is not necessarily a bad model. It's
Is
just
the Massachusetts horror story about access to primary care, is that real?
Oh, yeah. Absolutely. I mean, I think we probably mirror other sections.
Well, and I think clearly
we've got great spans of land that are geographically remote, believe it or not. I mean, you know, Boston is the exception, not the rule in terms of population.
everything between Boston and Springfield
Yeah.
is rural.
Well, between Springfield and Albany is
Yeah.
rural, let me tell you. It's the Berkshires and so on. Yeah, and we can't get people into those areas because that happens to be my market area. And you can't get primary care guys to go there. I mean, why, if you're a primary care, why the hell do you want to be located in some rural outpost? You know, you're married, your wife wants to go to the theater, and, you know, you get
Professionally
paid less,
isolated.
You're
Yeah.
professionally isolated. I mean, there
called
is
coverage
no
before.
motive to get you into the areas where you're most
But I
needed.
think it really keys up the fundamental question about does free enterprise competitive system, can it drive reform in healthcare? And you can argue about a number of aspects of it, but I just believe that when you start talking about the development of physician specialties in the right proportion to have an integrated health system, that the only thing that's going to drive that is dollars. And to do that, you're going to have to take dollars from specialists and reallocate them. And I don't think the market will do that.
That's where the
because
great food fight's going to occur.
There is no market mechanism to cause that to happen, because there's nobody who's going to give effective demand on the.
Well, who sets the fees?
Yeah. So it's going to happen, and you know, not to repeat, because you probably read my blogs, you hear too much about other countries, but that's what Britain does. They simply determine we're not going to train as many, because they have all the schools, we're not going to train as many specialists. And they pay primary physicians more than we pay primary physicians. And I will tell you, they don't pay specialists more than we pay specialists. That is a fundamental truth, and until we address that, you're not going to deal with the maldistribution of specialists.
Who sets Medicare payment schedules? Where are they established?
Congress, but they do it. They have that, what's that committee that makes recommendations? MedPAC makes recommendations.
MedPAC. Well, I mean, if you're going to change the model, you got to change the formula. And I guess
Right.
you got to start there.
Yep.
But that that.
And you get the blood in the streets argument.
Oh yeah, and that will.
People will be dying
Yeah.
because we don't have enough cardiologists and orthopedic surgeons.
Yeah.
And you've heard that whole
Oh yeah.
every doctor that walks in, if you don't do this, people will die, right?
Well, every time MedPAC makes a recommendation,
Congress overrules it.
Yeah,
Right.
they don't listen to it. It becomes,
And they get paid more money by people representing subspecialists than people that represent primary care physicians.
But if we all know that's the case, how do we attack it and restore some equity to the model?
See, I don't think you can attack it without a crisis.
well, that one you probably can't.
I just don't see how you go with these oxes without an utter collapse.
What do we have today? I think I've heard you all say we're in the crisis
Oh,
right
I don't,
now.
no, I don't think so. I mean.
So you expect GDP then to grow to the 20 and 25%?
Yeah.
Well, it may
I
not,
think
it may not
we have
reach
to-
there, but by the time it begins to approach it, there will be a fiscal crisis that compels.
So we forget the area of the advance in technology. There were several comments last night about oncology units that were built. And in 5 years they were empty because they were now done in doctors' offices. So I guess that's where I'm not quite as concerned about it going to 25%. It may, but on the other hand, I think we haven't, you know, if we would get some of the regulation out of the way, and that's easier said than done too, and allow some of these things to happen, it might not help the hospital side of the industry, that's true. On the other hand, it might help the delivery and the healthcare in the country in general. So I think we got to be careful about saying it's got to look like we think it looks today.
Well, I'm still not with you, though. You know, unless we address this primary care issue and the distribution, we're just, you know, treading water here. Right? And you're saying it's not going to happen. We can't do it?
He's saying not until there's a greater.
That's a different issue.
Right.
But
Yeah.
see, I think the other thing that we got to take in the equation, and that is the medical schools. They are a strong political, and so it's easy for us to say, yeah, we ought to do that from a hospital perspective. We also got to get the medical schools to go with us in that, and I'm not sure you can do that. I mean, that's going to be one big fight.
Well, medical schools are very rigid against making positive change of any
Yeah.
kind. I was talking to
That's what I'm talking about.
a
the
young
novel
doctor,
trend,
Yeah.
which,
That's right.
in your case, he said, I went into medicine because I wanted to take care of people. So I'm going into family medicine, and he's going to come work for us. He said every single member of the faculty came up to him and said, you're really a bright kid. What is in your
Yeah,
head?
what's wrong with you?
Yeah. So he had to be tough enough to do it. So I guess I'd go to Don saying, if I can't get enough primary care doctors, I'm going to get somebody else who can do primary care, because I can probably get that done quicker than I'll get doctors.
Nurse practitioners.
PAs, physician assistants, whatever.
Well, control the cost.
Why would any bright, enthusiastic medical student go into primary care? The investment time is 8 years of college, plus med school 3 years, residency, extremely long hours, low pay. Med school debt can be $200,000. When finished, you are at the bottom of the physician reimbursement pay scales. Nurse practitioners and physician assistants can become trained in half the time, do nearly the identical job, get the same reimbursement from insurance companies, not have to work nights, weekends, holidays.
We ought to invite that guy to this block.
If you were a medical student, realistically, would you do it?